Hello and welcome to the Centre for Eye Research Australia's 12th Annual Gerard Crock Lecture. My name is Olivia Hilton and I have the great privilege of being the chair of the CERA board. Before we begin tonight's proceedings, I'd like to acknowledge the traditional owners of the many and various lands we're all on tonight. I'm on Wurundjeri land and I want to pay my respects to elders past, present and emerging. It is now my absolute pleasure to introduce Elder Auntie Di Kerr for a welcome to country.
Thank you. I honour my ancestors and my elders, and I pay homage to the sacred ground that I'm on and all the sacred grounds that you're on. I wish to acknowledge any elders of different nations, any First Nations peoples who are across the waters, all Aboriginal and Torres Strait Islander peoples, and I acknowledge you all and I pay my respects to your ancestors, elders and families. It's an absolute honour and pleasure to be able to be asked to welcome you to country today, and it is a little bit different that we're on Zoom, and it's a wonderful thing, this technology these days, that we can get together and still be together during this pandemic. And we have suffered as a community and as a world during this time, and it's been a time of asking us to remember to take care of each other. And I know that you're going to be talking about Indigenous eye health and health and what's happening in the future. And I suppose in one way it's sort of a good thing that I've been given this welcome, because I'm actually recovering from cataract surgery. So at the moment I really can't see very well in my left eye. I'm just still recovering, so I'm hoping that I can see properly soon, and I have another catch-up appointment. And it was very different going to hospital, because you had to do everything on your own, and as elders we're not used to that, and we're used to having someone with us and being with us at all times. So things are a little bit different when you're going into hospital these days, that you haven't got that blanket around you, so to speak. You know, you're family that protects you. So I don't think things are going to change very drastically at the moment. So please take care of yourselves, and remember that we are still under pandemic law, and we still need to follow what the health department and what people are asking us to do. So I hope that you enjoy your conference, and can I just say that may Bunjil, our creators, surround you all and give you strength and resilience. And on behalf of my elders, I say Wominjeka, Wurundjeri Ballak, Yim Gundibig. That means welcome to the traditional country of the Wurundjeri people. But for those of you that aren't on Wurundjeri country, I can't welcome you to the country that you're on, but I can acknowledge the country you're on, and I hope that the elders and community where you are continue to take care of you and help you to keep safe. And I hope that Bunjil keeps you safe as well. So Wominjeka, all of you, and Nungodjan, thank you for having me, and I hope that you keep safe. Thank you.
Thank you so much, Auntie Di, for that incredibly warm welcome to country and reminder that we are in incredibly important and precious times, and we need to continue to care for one another, for community and for country. Tonight, I have the pleasure of introducing the 12th Annual Gerard Crock Lecture. The Gerard Crock Lecture series honours the memory of renowned ophthalmologist, the late Professor Gerard Crock, inaugural Ringland Anderson Professor of Ophthalmology. We're thrilled and so thankful that many of you could still join us tonight for such a special event on the CERA calendar. As Auntie Di mentioned, unfortunately, like many events held in this pandemic year, we cannot welcome you in person, but we're pleased that we can still bring this event to you online and honour Professor Crock's memory. Gerard Crock was always looking for ways to make a difference for patients. He was an innovator of eye research and an early adopter of technologies, so it's fitting that technology is helping us bring you this lecture tonight. It's also fitting that the 12th Annual Gerard Crock Lecture is being presented by another acknowledged Australian innovator, someone who has made an enduring contribution to eye research, blindness prevention and eye health policy around the world, Melbourne Laureate Professor Hugh Taylor AC. You may be aware that among many of Hugh's vast achievements is his role as the founder of the Centre for Eye Research Australia. For those of you joining us online, particularly our international viewers, a first for this lecture, the Centre for Eye Research Australia is an independent medical research institute. We are part of a world-leading biomedical research community based in Melbourne, Australia, and enjoy close associations with the University of Melbourne and the Royal Victorian Eye and Ear Hospital. Our team of basic and clinician scientists is committed to conducting research that helps detect and diagnose eye disease earlier, prevent vision loss, and restore sight. Our Institute's New Hope in Sight brand reflects our optimism for the future of eye research and what we can achieve for patients experiencing vision loss and blindness. I'd now like to introduce this video, which provides some examples of the work we've been doing in 2020, in spite of many challenges, and our vision for the future.
Well, when I arrived in 1990, the Melbourne University Department of Ophthalmology had 5 people in it, and I was the 6th, and we were tiny. And obviously there was huge potential, and we needed to somehow harness that potential and grow the importance of ophthalmology, the academic values, the research capacity, which we're just going to call the Centre for Eye Research.
2020 has been a uniquely challenging year, but it has highlighted the importance of medical research and the work that CERA does. So we're really excited about continuing to develop the technologies that we're using to improve the lives of patients with vision loss and blindness. So we've really tried to keep the momentum going through this year, to keep progressing our research, and really to do some of the things that Hugh Taylor had the vision to set up when he established CERA.
Technology is transforming eye research. We're seeing advances in imaging technologies, which mean that we can see aspects of the eye that we've never been able to see before.
My research involves using artificial intelligence to early detect the signs of a condition known as keratoconus. I hope that my research would be able to improve the quality of life of these patients.
The research that I do is based around trying to predict who's at highest risk of progressing from the early stages of macular degeneration to the later stages, which can have a real serious effect on someone's vision and ability to see.
Finding new treatments is what we're here to do, and there have been real advances in developing new treatments for vision loss and blindness, but there are still patients that we can't treat, and that's the focus of our work. We want to slow down vision loss in those patients, and we want to restore the vision that they've lost to improve the quality of life.
My research is in glaucoma, and recently we've been investigating vitamin B3 to look at whether you can protect nerve cells and prevent their damage to prevent vision loss in glaucoma. Current treatments for glaucoma are all targeted at lowering eye pressure. However, we know that some people can still progress and lose vision despite treatment. So new therapies to help these people are always important.
Clinical trials are important because they are the most scientific way of making sure that a treatment actually works and is safe.
Well, gene therapy can be used in a whole variety of different ways in the eye. And in my work, developing new treatments for glaucoma, we use gene therapy to make the optic nerve more resistant to injury. And ideally that will preserve vision of patients and hopefully also restore vision when patients have lost it.
My research is trying to produce a tissue-engineered cornea.
We're going to use stem cells, which are created from either skin or blood cells, and use those to build corneal transplants in the laboratory. About 12 million people worldwide are waiting on a donor cornea and can't get one.
My hope for the research is that we can provide corneal donation tissue-engineered cornea to everyone in the world who needs it.
It's an amazing time to be involved in eye research because a whole range of different technologies have come together with an improvement in our understanding of how the eye works to make things that we couldn't really conceive of a few years ago now possible.
When you do research, you not only help every single person that you see in the room, you actually have the potential of improving the life or the vision of people around the world. That possibility of really making a difference to so many people is what I think drives most of us here at CERA.
Thank you again for attending tonight's lecture. I'd now like to pass you on to one of the stars of the video you just watched, CERA Managing Director, Professor Keith Martin.
Well, thanks, Olivia. I don't know about star of the video. That's really the researchers who are doing the vast majority of this work. But Welcome everyone. This is the 12th Crock Lecture, and this is not the year any of us were expecting. It's been an unusual year, but out of adversity comes opportunity, and so I'm delighted that we are able to use technology to bring you a whole new type of Crock Lecture, which is now gone digital. And I'm delighted that so many of you are joining us from around Australia and around the world. So we'd have loved to see many of you who often attend this event here in person, but in the absence of that, I think we have a great program for you this evening. So welcome to those of you who are joining us, and we have registrations from around the world. We have more than 300 registrations for this event this evening, from the US, from Canada, from Africa, from Nairobi, from Kampala, from Canada. We have registrations from the UK, from Cardiff, and also some of my colleagues from Cambridge. Now, you may not know, but Hugh was due to give or to chair the Cambridge Ophthalmological Symposium this year in September, which was on this very topic, Vision 2020. And that meeting was cancelled due to COVID. And so I'm really pleased that quite a few of the people who had registered for that meeting are joining us today. So welcome to those from Cambridge also. And welcome to those from around the world that are joining us too. The Crock family are very important to this whole event, and we would really like to welcome Jackie Crock and members of the Crock family. We're really extremely honoured that you continue to support this event and continue to support all of the work that CERA does. So great to see that you're able to join us this evening. Welcome to colleagues from the University of Melbourne, and welcome to the Vice-Chancellor, Professor Duncan Maskell. Welcome also to colleagues from the Royal Victorian Eye and Ear Hospital, and in particular, Chief Executive Officer Brendan Gardner, who's joining us this evening as well. And welcome also to our CERA board and all of our international research colleagues, our generous donors and supporters, and also to our wonderful CERA staff, many of whom are joining us this evening too. So a few housekeeping pieces of information. So we will give you the opportunity to ask questions throughout the lecture this evening. So please type those into the box that will appear at the bottom of your screen if you're watching the webcast. If you're on Facebook, then you can leave comments underneath the live stream. And tonight's presentation is being videoed, and we will provide you with the link afterwards that you can watch again if you so desire, or provide to others if you find it interesting and you think they may be interested too. I'll spare you the usual housekeeping. I'll leave you to find the fire exits in your own home, and toilet arrangements are up to you. So with that, we'll move on to introduce our guest of honour tonight, Professor Hugh Taylor, and it's my enormous pleasure to introduce Hugh, who is Melbourne Laureate Professor Hugh Taylor, AC, and he is currently the Harold Mitchell Professor of Indigenous Eye Health at the University of Melbourne. But we know him around CERA as our founding Managing Director. He established CERA back in 1996. And Hugh is internationally recognised as an outstanding clinician scientist. So he's known for his rigorous combination of epidemiological studies, but also for his pragmatic and practical way of putting his research into action to actually change policy and to change outcomes for people with eye disease. So he's an inspiring teacher and has led many international organizations around the world over the course of many years. And I think, and Hugh will cringe here, I'm sure, but he's probably made a greater contribution to the burden of global blindness than any other Australian, I think. A huge reach of his research and a huge commitment translating that into new treatments or improving the delivery of existing treatments. And really, Hugh's population-based studies have defined the agenda for eye research in this country and led to the implementation of really much needed new programs, particularly in Indigenous eye health. Perhaps his greatest contribution has been in the field of trachoma, where he's been the architect of much of the progress, working together with the World Health Organization in working towards the elimination of this disease worldwide. And in actual fact, I really got to know Hugh a bit better because he did his sabbatical back in 2006 in Cambridge. And so I was his academic host at the University of Cambridge, and Hugh came over to write his book on trachoma, which is really the landmark publication in the field, and made a great contribution to our local teaching of residents, and really threw himself into the life of the department back in Cambridge during his time there, as well as churning out a book. So he's an extremely productive guy when given a bit of time to do things. Hugh is really a giant in the field of ophthalmology, and I'm proud that we are continuing his legacy at CERA. So it gives me great pleasure to invite Hugh to deliver the 12th annual Gerard Crock Lecture. Hugh, would you like to join us? So welcome. And just before we start, while we have you, have a seat. To get the evening rolling, I just wanted to ask you a little bit about what you were thinking when you set up CERA back in 1996. So what were you hoping to achieve? What were you trying to achieve that you couldn't get done in other ways?
Well, I had ridiculous ideas of trying to set up a world-class eye research institute and group in Melbourne, in the bottom right-hand corner of the world. And I'd arrived in 1990, and as we saw in that little video clip, there were 5 of us when we started. And we'd worked hard to try to raise money and to try to build it, but there was quite a lot of antipathy with town and gown. Research wasn't really very kosher. And there was an Ansell Foundation that had been set up with donations while Gerard Crock was still around. And the board, I talked with that board and with other people and thought, if I can bring people together and get the critical mass, we could really start doing stuff. And so we brought together the University Department of Ophthalmology and the Idea Hospital, the non-government organisations that were related to eye care, the Lions who were already funding the eye bank, and the groups that became Vision Australia, and Christian Blind Mission, and then also the College of Ophthalmologists. So we brought those together and said, all right, let's see if we can't all work together and set up this Centre for Eye Research Australia. And the way it's grown and developed is just amazing.
Yeah. Well, it's testament to the vision of getting the whole thing started. And for those of us that follow on, the first priority is not to break it, and the third is to try and keep it moving forward. But I'm also curious, what does it feel like when you move on from that role to a different role and see what's happening? Do you want to get back involved again, or do you?
No, well, I was obviously very anxious that the whole thing just wouldn't fall over. And often, if there's somebody who sets something up and moves on, that can happen. But I think the leadership with Tien Wong and then Jonathan Krause and now you, the centre has just gone from strength to strength. It's now one of the top 3 or 4 eye research centres in the world, which is just extraordinary, really. And so I've been, having watched a number of directors of institutes that I've been in over time, to see that to be interested and available if there are questions, but to keep well out of any of the decision-making is the best way to do it. And so that was one reason why I physically moved out of the Idea precinct to the position I have at the university, but hopefully always available on the phone or on email to give any help or advice or answer questions if they come.
Yeah, and finally, Hugh, the new role that you have now. We're going to hear today what you've been working on, but what's your ambition for the 5 years to come? And I don't want to you don't spoil the plot here when it comes to your lecture.
You mentioned I did a sabbatical in Cambridge in 2006, and when my wife and I were sitting on Jesus Green at some time, I casually said, "Oh, why am I having this much fun at work?" And that's got me starting to think that if I had another good 5 or 10 years' work, this is in 2006, remember, and I could do one thing, I thought it was not good to spend 28 years as head of CERA. It was better to let somebody else take over, because new ideas and new management are really important. And I thought if I could do just one thing, I would, if I could address the disequity in eye care and eye health for the Australian Aboriginal and Torres Strait Islander people, that'd be worth doing. So that's what we started off doing 12 years ago.
Well, okay, well that's
and we go to close the gap division and get equity in eye health
Fantastic. Hugh, let's hear where we are. The stage is yours, and go for it.
Thank you very much. Thanks, Keith. And thanks, Olivia, and also particularly thanks to Auntie Di. And I would also like to thank the people and friends who are listening into this from around the world. I'm really very honoured to be giving this talk, and I do want to start off by paying my respects to the Aboriginal and Torres Strait Islander people. And I show this map that shows the languages, the more than 250 different language groups across Australia at the time of the European colonisation or invasion. And I want to pay my respects to the elders past, present and emerging of this land that's never been ceded, always was and always will be Aboriginal land, and the more than 2,000 generations of Aboriginal and Torres Strait Islander people who've lived on this country. So it truly is an honour to be able to work and do this, the work we've been able to do. And it's a great honour to talk about Gerard Crock, and we have heard a little bit about him already this evening, but he was grew up in Perth and did his first year of health training in Perth in the dental school, because there was not a medical school in Perth at the time. And then he and his twin brother Harry came to Melbourne. They shared the Preceptor's Prize for Anatomy in their second year. When Gerard had finished his training, he then went to Moorfields in London to do further training, and then spent some time at the Wilmer Institute as well. And it's interesting to see that he was a fellow of the College of Surgeons, the Australasian College of Surgeons, Australian College of Physicians, as well as in ophthalmology. And from 1963, he was the Foundation Ringland Anderson Professor of Ophthalmology at the University of Melbourne, and was the first specialist professor in Australia in a medical specialty of any specialty. And he made extraordinary contributions in retinal imaging, microsurgery, and a lot of innovation in teaching. And as I mentioned in the discussion with Keith, there was a certain amount of division between the town and the gown. What's this professor doing? All our patients want to go to see the professor. And it was really tough to get to build that research base, which he did extraordinarily well, and encourage many people as well. And so this is a photo at the 40th anniversary of the Melbourne University Department of Ophthalmology, or MUDO, which was the antecedents for the Centre for Eye Research Australia, with Gerard Crock talking at that 40th anniversary and showing one of his inventions, the contact lens corneal cutter, that was a major advance in corneal surgery. Gerard was very well recognised internationally. He was a member of the International Council of Ophthalmology. He was one of the foundation members of the Academia Ophthalmologica Internationalis. He received the Order of Australia and was a Knight of St John. And here's a photograph with Gerard and his twin brother Harold in front of the portrait that was painted of Gerard that sits in CERA now. But I'd like to give a little bit of a historical perspective, because 2020 was going to be a really great year for eye care, a year of great celebration, and it didn't turn out quite the way we thought it was going to. But in 1994, the work was done through WHO and other groups that estimated that there were about 45 million people blind in the world at that time. And about 60% of that were things that we could fix up pretty easily, cataract and refractive error. Other things needed a public health approach, like trachoma, vitamin A deficiency, or onchocerciasis and river blindness. 15% of things were hard to treat and needed long-term chronic care, particularly diabetic retinopathy and glaucoma. And there was another 10% of things that we just really didn't know what to do anything about and couldn't really handle, which was age-related macular degeneration and then other diseases that really were not readily amenable. And so taking those figures, by 45 million blind in 1996, it was estimated that would double by 2020 to be at least 90 million people blind. But if we did what we knew and could control those controllable causes, we could reduce that rate down to about 25 million as an estimate. And so this led to Vision 2020, the right to sight. And this program was launched in 1999 with the goal of eliminating avoidable blindness by the year 2020 in order to give all people in the world the right to sight. And this included 3 strategies. One was disease control, looking at cataract, trachoma, onchocerciasis, childhood blindness, and refractive error and low vision. The second area was looking at resource development, human resource development, and then thirdly, infrastructure development. And so Vision 2020, the right to sight, became a real catch-call. And of course, it meant the right to sight for all people in the world, not just everybody except Australians. So we also set up a group, Vision 2020 Australia, that did a lot of work here in this country on its own too. And so Vision 2020 was a joint initiative between the World Health Organization that provided technical assistance, the International Agency for the Prevention of Blindness that brought together all the national or the international non-government organisations who provided support and capacity building, working with national partners to develop national plans and really trying to deliver eye care in a better way. Then some years later, the World Health Organization and the World Health Assembly in 2013 enacted or passed their Global Action Plan with another target for a 25% reduction in avoidable vision impairment by 2019, looking at the prevalence and cause of visual impairment, the cataract surgery rate and coverage, and the number of people providing eye care. And each member state, including Australia, had to report back to the World Health Assembly on the progress they were making. And this was the idea of trying to provide universal eye care. And actually, there were some very significant changes. The graph there shows the dramatic increase in cataract surgery being done in India and also in China. And then the table at the top shows for MSVI is moderate to severe visual impairment, where there's, and the other set of columns are for blindness. And the prevalence of these conditions had decreased about 25 to 40%. So a very dramatic reduction in the prevalence, the percentage of people with it. But the actual number of people had increased some. And as the population is ageing and as the population is growing, so although we were making significant progress in reducing the rates of blindness, the actual numbers were still increasing. And this complicated table, the first column shows mild vision loss, the next one shows moderate to severe vision loss, and then the one in purple is blindness. But the point is, for each of these bars, for each of these 17 regions, these bars are almost all pointing to the left, which shows significant reduction in the rate of blindness in each of these regions over the last 20 years or 30 years. And so there's some really good progress being made, even though there are still very significant numbers. And this is, again, more data from the Vision Loss Expert Group, led by Rupert Bourne in Cambridge, showing the rate of blindness and severe, moderate to severe vision loss for men and women by age, and how the rates go up dramatically over the age of 50 and continue to increase. And so again, with the increase in population and increasing ageing, these numbers will keep growing. And this shows the distribution of vision loss globally, with particular emphasis on those hotspots in Africa and in Southeast Asia, and then a similar sort of picture if one looks at rates of blindness. And so this is a problem around the world, but particularly in the low and middle income countries. And if one looks at the causes of blindness, this shows cataract is in blue, and cataract is the leading cause of blindness in most regions of the world. Refractive error is important, and in many areas. There's a range of other conditions, but particularly looking at cataract, refractive error, glaucoma, and age-related macular degeneration are the major causes that we're confronting at the moment. And if you look at the projected numbers over the next 30 years to 2050, there's projected to be a dramatic increase in numbers, even if we can keep that prevalence rate low and decreasing, just with the population growth. So there is a lot of work to do. Now, in 2015, the United Nations put together the Sustainable Development Goals. And there are 17 of these that are quite wide-ranging to really try to address the areas of poverty and disequity around the world. 6 of them particularly relate, or relate one way or another directly to eye care, reducing poverty, reducing hunger, providing proper diets, providing proper water and sanitation, addressing inequities and people working together. But the main one is goal number 3, SDG number 3, good health and well-being. And in that, there are 3 particular areas that are relevant for us. One is on neglected tropical diseases, which includes trachoma and onchocerciasis. Another is health financing and the health workforce. And the third is universal health coverage to really provide effective health care to everybody in every country. And the WHO has taken UHC, or the universal health coverage, as a major area, with the goal by 2023 to have their triple billion target. So that would be 1 billion people covered with universal health care, 1 billion people protected from emergencies, and a further 1 billion people with better health and well-being. And the thrust there is if you take the current funds and increase the funds so that all the population is covered, not just a few of them. To increase them in the other dimension, so that all the services are covered, not just a few services are covered. And then in the third dimension, to increase those so that people can afford healthcare costs and not go broke or have to mortgage their house to try to pay for healthcare. So it's those 3 ways of trying to improve and achieve universal health coverage. Then last year, in 2019, WHO released the World Report on Vision. And in some ways, this built on what we knew. It built on the fact that there are a lot of people with undercorrected refractive error and cataract and glaucoma and corneal blindness and diabetic retinopathy and trachoma, and lots of people with presbyopia, all adding up to about 1 billion people with eye care needs. But to that, they added another 1.2 billion people who are already wearing glasses or maybe contact lenses, but who need to have ongoing eye care. They are disabled and can only function normally because they're using their aid or their device to see. And they will need a new pair of glasses. So if you're looking at the numbers of people who need eye care, you need not only focus on those who've got undercorrected refractive error or unoperated cataract, but also those people who do need to have regular eye exams and treatment or correction. And so this World Report on Vision is really a game changer. And this was accepted and adopted by the World Health Assembly this year, led by Australia, that was the mover of the motion, and seconded by Indonesia. And there were 5 things that the World Report of Vision called for. It was to make eye care an integral part of universal health coverage, to implement what they call integrated people-centred eye care into the health systems. And the IPCEC is a lousy acronym, but that's what we've got. To promote high quality implementation and health systems research, to monitor what's happening, and to make sure that people are aware of the need to access the eye care services. And so this integrated people-centred eye care was about empowering and engaging people in communities, building an integrated system from in the community and primary care through secondary and tertiary care, and making sure that it was coordinated with the mainstream health services across the particular country. And then we look at the number of ophthalmologists in the world, which is along the bottom axis, and the amount of blindness, which is on the vertical axis, and the size of the country, which is the size of the spheres. We can see that where there are lots of ophthalmologists, there's not so much blindness, but where there are lots of people in their big circles, there aren't so many ophthalmologists and there's a lot of blindness. Now remember, ophthalmologists are not the be-all and end-all. They are only one of the people in providing eye care. So if you look at the map with ophthalmologists and optometrists, you still see the same thing. You see there is great need, particularly in the developing areas, in those large countries, for a lot more eye care delivery. And if we're looking at integrated, people-centred eye care, we have to be training more ophthalmologists, that's obvious. But it's not the whole solution. We actually need to be working on eye care teams to meet the needs of the community. And we need to make sure that this comprehensive eye care is properly integrated into the healthcare system, so it's sustainable, not standalone. And we need to make sure that from the primary care level in the community, there is integration up into the healthcare structure. And so that those who are trained need to have the support that they require, both in infrastructure and in the continuing professional development. And this is an area where the International Council of Ophthalmology has made a lot of contributions in terms of education and training and a variety of programs, and really trying to empower societies and provide global leadership. And I mentioned this, I was the president for 4 years of the International Council, and we're just delighted to see that the next World Ophthalmology Congress will be held here in Melbourne in 2022. I want to change tack now so that there's a lot of work, a lot of progress being done in internationally, and a lot of commitment to improve and develop the eye care services. But as we mentioned in some of the discussions, in 2008, I left CERA and started working in the Melbourne School of Population and Global Health to set up a little group working on Indigenous eye health called Memento, which is the Wurundjeri name that was given to us, which means tracking eyes. And we now have a staff of 15 people, and we're working to try to close the gap for vision and provide equity and eye care for Indigenous Australians. And when we started, the National Eye Health Survey, a National Indigenous Eye Health Survey done by CERA at the time I was leaving, showed that there was 6 times more blindness in Indigenous people. And it's important also just to briefly look at the distribution of Aboriginal and Torres Strait Islander people across the country. On the one hand, at the bottom left-hand corner, the graph shows the very different age distribution, where there are many higher percentage of younger Aboriginal people. Over a third of them are under the age of 15, where only about a sixth of the non-Indigenous people are under the age of 15. And then those over 65 are only 3.5% of Indigenous people, compared to 14% or more of non-Indigenous. The other thing is, Aboriginal and Torres Strait Islander people live in our towns and cities. 3/4 of the Aboriginal and Torres Strait Islander people live in urban areas. And it's only about 25% that live in the remote or very remote areas. So when we're looking at what do we need to do for Aboriginal and Torres Strait Islander people, we need to think of the whole country. These are not just people living outside Alice Springs. So the National Indigenous Eye Health Survey, as I mentioned, done with CERA, showed that while Aboriginal children, Aboriginal and Torres Strait Islander children had much better vision than mainstream, the rate of blindness in adults was 6 times higher. And almost all of the vision impairment was unnecessary. 94% of it was avoidable, and a third of the people had never had an eye exam. And we knew what the main causes were and what to do about it. With cataract, you need to provide people with surgery. With diabetes, you need to have regular exams and injections or laser. For refractive error, you just need a pair of glasses. And for trachoma, there was this WHO strategy, the SAFE strategy that I'll talk about a little bit later on. And so most of this could literally be fixed overnight. If you give somebody a pair of glasses, they see right away. And after cataract surgery, you're going to see the next day. And Auntie Di, if you're still listening, I'm sure your vision's going to be a whole lot better after your cataract surgery. The other thing was that the vision loss caused 11% of the health gap. And the amount of vision loss and the number of people blind and vision impaired would double over a 20-year period if we just left things the way they were. The other thing that I found just shocking or surprising was that the unmet need for eye care in Fitzroy or in the urban areas is the same as it is in Fitzroy Crossing. And in the remote areas, clearly we need to have a whole lot of services. But the Victorian Aboriginal Health Service at that time in Fitzroy was less than a mile from the Royal Victorian Eye and Ear Hospital, the largest eye hospital in the Southern Hemisphere. And what we had to do was to get people to walk back and forth across Victoria Parade. So while in the remote areas, there are a whole lot of things that need to be done, there are also similar things that need to be done in the urban areas as well. And fortunately, I'll say, the Eye and Ear and VARs have done a super job over the last couple of years in really transforming that provision of eye care. But we said the patient journey or the pathway of care was like a leaky pipe. There were lots of gaps and cracks along the way where people would fall out of the system. And in 2012, we launched our roadmap to close the gap for vision. And we identified 42 leaks or things that needed to be fixed, 42 recommendations, particularly looking at areas of community engagement and working with the Aboriginal community-controlled health organisations, recognising the critical importance of cultural safety, linking primary care with the regional specialist services, and using a multi-layered approach. And we were really striving to get equity in eye care. So we were using a health systems approach and evidence-based, based in primary care with community engagement, using a multi-sectoral, multi-level, multi-strategy design to cover those 42 recommendations and building on regional areas, but focusing on cultural safety and appropriate care, and also making sure what was done was measured. Because if it's not measured, it can't be managed, and if it's not counted, it doesn't get done. And so we're really building regional networks of stakeholders and partners. Based around a hospital where cataract surgery can be done, there is no point in flying somebody from the Kimberley to Perth to have cataract surgery, or from Dumaji up in the Gulf of Carpentaria to Melbourne to have surgery. It needs to be done locally or regionally. And so we're looking at collaboration to make sure they have the service provision to meet the population-based needs. So there's enough optometry visits, ophthalmology visits, case management visits or support to meet the population-based needs, and develop the local mechanisms and referral pathways for case management and oversight. And we've now got groups up and running in 59 of the 64 self-defined regions that cover approximately 95% of Australia's Aboriginal and Torres Strait Islander people. One of our particular focuses has been on eye care for people with diabetes. As over a third of the Indigenous adults have diabetes, everyone with diabetes is at risk of blindness, and with appropriate examination and treatment, up to 98% of the blindness from diabetes can be prevented. But once vision is lost, it can't be restored, usually. And somebody who's blind from their diabetic eye disease can't manage their own drugs or check their blood sugars or check their feet, let alone get to the doctor or to start home dialysis. So we've had a particular focus on diabetic eye care. We're building and strengthening primary care where we can get screening with these retinal cameras and a change in a Medicare item number. And there are now 155 retinal cameras provided to the Aboriginal Medical Services, as well as a lot of health promotion material for people in the clinics and particularly those with diabetes and the community. We've also been doing a lot of work on trachoma. And trachoma is this blinding eye infection that starts off in little kids, but usually ends up causing blindness in older people. And Australia is the only developed country to still have trachoma. It disappeared from Melbourne in 1904 when the ophthalmologist in charge of the eye and ear said he could no longer find cases in Melbourne of trachoma to teach the residents, and he had to bring in people from the Goulburn Valley or Gippsland. But it used to be called Sandy Blight, and it really disappeared 100 years ago from mainstream Australia. But it's still a problem in 44 countries. In the last 10 or 12 years, there are now 13 countries that have eliminated trachoma, and I heard on Monday that Vanuatu now thinks that it's eliminated trachoma. And while the goal was to eliminate trachoma by 2020, the revised goals that came out earlier this year, there'll be 8 more countries that should have eliminated by the end of this year, and then all by 2025. But with trachoma, every child with a dirty face is a health hazard. And children need to have something like 150 episodes of infection to cause blindness. Each episode only lasts for a period of some months, but each one causes more damage and scarring. And so transmission is stopped by keeping every face clean. So our message has been clean faces, strong eyes. And we've done a lot of work with health promotion, working with this SAFE strategy, which is surgery for the interned eyelashes, the end result, antibiotic treatment, but particularly on the facial cleanliness and the environmental improvement to improve hygiene. With Milpa, our trachoma goanna, who's become the mascot and is widely seen, and a whole range of community events, including working very closely with the Melbourne Football Club, that have been great supporters and ambassadors for this work. We've also been focusing on the need to have clean and safe and functional bathrooms as part of the hygiene, because if we can, children, you can't wash your face without washing your hands, so good hygiene not only stops trachoma, but also otitis media, respiratory infections, gastroinfection, and skin infections that go on to lead to rheumatic heart disease and glomerulonephritis. And of course, the COVID-19 emphasis or need for good hygiene has also worked in well with the messages that we've been working for trachoma health promotion. Oops. And the rates of trachoma have come down dramatically from when we started in 2008, there was 21%, down to about 4 to 5%, but it has stabilised over the last few years. So there's still more work that needs to be done to really make sure we eliminate trachoma. Now, we are making good progress, and of the 42 recommendations that we reported last year, November last year, 21 had been fully implemented. And tomorrow afternoon, we're launching our next annual update, which I can't tell you all about it, but obviously COVID-19 has had a big impact on the activities. But I think by working together, we will close the gap and end avoidable blindness. And we've now got over 90% of the recommendations have been fully implemented. So we are making really good progress. A couple of weeks ago, the Australian Institute of Health and Welfare launched their report on eye care, Indigenous eye care, which is one of the important recommendations we put in place. And you can see in each of the jurisdictions, the number of healthcare assessments that include a vision test in the older people has increased dramatically year on year, which is wonderful to see, really building in primary care. The number of eye exams, again, for each age group are increasing, but the pale bars show how much shortfall there still is from the eye examination rate in non-Indigenous people. So we are making progress, but there's still more work to go. Again, when we look at the rates of cataract surgery, both for those 65 to 74 or those 75 above, we can see the rates are increasing progressively year on year for Aboriginal and Torres Strait Islander people, but are still quite a long way behind those for non-Indigenous people. So again, good progress, but still more work to do. And when looking at the distribution of cataract surgery across the country based on population needs, you can see it's very variable with lots of pale areas where there's just not enough surgery being done, particularly in the large towns and cities. And then finally, just with diabetes, again, the number of people being tested increasing year on year, or the percentage of people being tested increasing year on year, although still behind the non-Indigenous rates. So documenting the impact is really important. What AIHW can show is the number of services, but we started off with the National Indigenous Eye Health Survey that CERA did in 2008, followed by the National Eye Health Survey in 2015 that showed the rate of blindness had gone from being 6 times more than mainstream down to 3 times, a dramatic reduction, but still unacceptable. And just in the last couple of months, the funding for the next National Eye Health Survey has been gone. We'd hoped we'd have the results in 2020, but we won't get those results until 2021 at the earliest. And it's really important to document those changes in blindness rates in the end. So in summary, there's been some really good progress globally with the work on prevention of blindness. And this new WHO initiative with the World Report on Vision, I think, is very exciting. The Indigenous Australians still have a lot of unnecessary blindness and vision loss, and there is a real vision gap. But we are making some really good progress to address this, and those recommendations in the roadmap to close the gap for vision are making a real difference. And the gap for blindness has been halved. So with a bit more work and a bit more effort, I'm sure we will end up reaching our goal of closing that gap and bringing equity in eye health. Thank you.
Hugh, that's a fantastic lecture, an absolute tour de force of everything that's going on. And what we're going to do now is just pause for questions, and then we can give a formal thank you to Hugh. And so I'm going to join Hugh across here, and we've had some questions that have been coming in over the course of the lecture. And in these days of Zoom, we have a very high-tech approach to questions. We found an extremely thin screen that doesn't require any battery and is very portable and can be easily recycled. So moving with the times. So Hugh, one of the questions that came through during your talk was, once you close the gap on eye health, what's next?
Well, basically what we're learning is how to link primary care with a visiting specialist service. So if it works for eyes, it should work for ears and hearts and lungs and kidneys. So I would hope that the lessons that we've learnt with eye care will be very relevant to the provision of other specialist care. And of course, one of the good things about eye problems are we can actually fix them. So you give somebody a pair of glasses, they see. You do cataract surgery, they see. Whereas, if you've got renal failure or heart disease or hypertension or diabetes, you're going to need to be treated all the time. So eyes were a really good place to start off with, but I think it'll show how to link those other specialist services.
Yeah. I think there are nice examples of that around the world as well. When you look at LV Prasad and others that have used, the eye care to then
leverage other things.
Right. So yeah, absolutely.
Right.
Yeah. Good. Okay. So another question that's come through. So with such a focus on COVID-19, how do we keep Aboriginal eye health on the agenda?
Well, that's been a real challenge, and it's variable, obviously, with the different states, with the different areas that have been closed down and opened up at different times. The Aboriginal community controlled health organisations have done a fabulous job taking the lead in keeping the Aboriginal community safe. I mean, I think there's only something like 80 or 90 cases of COVID infection in Aboriginal people, which is almost 900,000 people. It's fabulous. Yeah. And I think that shows their leadership. And so what we need to do is we need to, and it's starting to happen. The services are starting up, particularly in the Territory and WA. Those services and in South Australia as well have been running back to those communities. Again, in the last month or two, starting up again in Queensland and some in New South Wales. And we need to make sure we get the clinic at VARS and running full time with all the cases coming into the eye and ear with high priority.
But a follow-up to that really is, as well as the clinical service, how do we actually do research and gather the data in these communities post-COVID? And, what are the issues that you're facing going into those communities?
Well, I think that we've not been able to do most of those visits. We do have 3 staff based up in Alice Springs that have been doing a lot of work in the Territory. But we've been unable to travel sort of since March. And so in the communities and regional groups where we've already established the relationship, we can do a lot on Zoom and email and what have you. But where you try to start things for the first time, you really need to be there physically. And we had people plan to go to Adelaide on the 1st of December. But I think all those plans have been pushed aside from Monday. And so I think we're just going to have to play it by ear. It's a real challenge, and I think it'll be different in different parts of the country.
Okay. Good. Well, here's a googly for you. This is from Daniel Feller. So do you feel that the TGA, the therapeutic goods, is a better body to approach than the FDA at present when it comes to anything to do with progress?
We have not had to rely much on the TGA. The real thing was getting azithromycin approved for the use in trachoma. And that happened 20 years ago. But the approval there was just for the paediatric dose. They forgot about treating adults. And so we had to then go back and get them to change that. But it's more the Medicare benefit schedule than the Therapeutic Goods Administration that has been the rate limiting step. And the biggest block that we really have, I think, in many ways, is the public hospitals, which are state or territory run, jurisdictionally run, where there's long waiting lists for surgery. But that's only after you've waited for several years to get into the clinic to be evaluated. And the idea, again, has really revolutionised that with its fast-track cataract service and the linkages with VARs. And the Sydney Eye is now learning some of those lessons and changing things. But the other hospitals in Victoria or in the country basically need to do that. And we have to make sure there's good access for the intravitreal injections. Because they're available, they're approved in Australia, but there are not the public services where people can get the treatment. And it's the cost uncertainty or the gap fees that people get charged in private that's a huge barrier.
Right. We've partly answered the question, but there's a question from Penny Allen following on from that. What can ophthalmologists in Melbourne do to help?
Well, I had an email from Tim Henderson in Alice Springs on Monday or Tuesday, who was desperately looking for another full-time ophthalmologist in Alice. Now, I don't think Penny is likely to move up, but Penny, think about it. It might be really good. But the other thing is that in so many of these places, we're really looking at having fly-in, fly-out ophthalmologists, because they're small communities or small regions. There's not enough work for somebody there full-time. But to go there for a week every 2 months or something, or to be one of a group of 2 or 3 people who go back and forth regularly, can make a huge difference to providing these services in these outback areas. And also encouraging our trainees on the importance of providing eye care. And that's why the idea link at bars is so important, to get the registrars there so they have that experience and recognise how satisfying it can be.
And some of the most grounded trainees that we have coming through have actually spent time with Angus Turner or others on those programs with the Lions back in. It's a fantastic way to start in a career, but also later on, as a way of giving something back.
To see what the issues are, to see what can be done, to see how rewarding it is a terrific thing for the young people to start thinking about how they fashion their career.
Fantastic. So a couple of late questions as well coming through. So. So another one from Penny. Penny, we'll give you one more. How do we ensure that diabetics get eye examinations?
Well, I think there was something of the 42 recommendations, there's something like 34 of them relate to diabetes. And part of it was getting a Medicare item number for retinal photography. Part of it was getting the retinal cameras out there so that it could be done, and people in the Aboriginal Medical Service trained how to use them, and being the clinics or GPs being reimbursed for doing that. Part of it was setting up the referral networks. Part of it is the health promotion. Part of it is actually monitoring what percentage of our people with diabetes are actually getting examined. Part of it is to make sure that things like OCT are out and available. Another part is to make sure they've got access to no gap fee service, which is either ophthalmologist, not bulk billing, or proper public services where they can be seen and treated. So there's a whole series of things that need to be done, and we are making progress on each of those. but we haven't got them all fully implemented yet. And that's where you've still got that push to go.
And I think that's where, CERA is continuing to contribute. And I have to give a shout out to Peter van Wijngaarden and the team with the Keep Site program, which is really making a big impact, I think, in terms of making sure that the screening is in place.
Yeah, so it's a super program, and as a way of reminding it. Now, the number of Aboriginal and Torres Strait Island people who are involved in Keep Site percentage is not as high as it is for mainstream, but it's growing and progressing. And I think there are lots of ways to skin a cat. There are lots of things that you need to do to get those messages through.
Okay, and another question coming through. So how can AI assist in detection and management of eye disease in Indigenous peoples?
Well, if we had AI built into the retina camera and the light went green, yellow or red with diabetic retinopathy, that meant it's okay, come back next year, be referred in 3 months, be seen within 3 months, or be referred and seen within a month. That'll be terrific. But I think right at the moment, a lot of that can be done on the spot with minimal training. And we've got the online training that we've developed with CERA, and it's sort of case recognition. And it's really important that it's done at the time, because if it's sent off for to get a result to come back 48 hours later, the patient's gone. Half of them, and the US shows half of them don't come back, don't make an appointment, and half of those who make an appointment don't come. So you're only getting a quarter of the people. But if you show them the photo and say, "This is your photo. Look at all that red. This is really bad. We've got to get you to see Professor Martin or whoever, Betty Allen, by the end of the month." That has such a patient education component in it. But if the red light goes off in the camera, you're getting the same message.
Great. And so a question from Elizabeth Crock. Do remote area nurses help with eye exams?
Absolutely. Absolutely. And I think it's part of the adult health check is to check for vision and ask about vision problems. And if people have diabetes, to make sure they're getting their eye exam done. And in some areas they've been trained to do the retinal photography and photo grading. So the nurses are critically important.
Yeah. And perhaps a final word to somebody you may know, Liz Dax.
Oh no, this is trouble.
And it's not your flies undone, Hugh, so you're all right here. So are the Indigenous self-determined responses key in eye health programs?
I think that the community ownership and engagement is really important. It's empowering the Aboriginal community-controlled health organisations. And as I said at the start, they've done such a good job with controlling the spread of COVID and stuff in the community. It just reinforces how critical and how important they are. So we must be doing these things with people, not to people. And that's really important.
Hugh, I think that's a great place to finish. So thank you so much. Thank you. I'd like to just thank you for giving us a real tour de force lecture this year. I'd like to present you with a little memento of the evening.
Goodness.
And so this is a piece which has been created by Indigenous glassworkers in Geelong. And as a token of our thanks. So Hugh, thank you very much, and you can listen to the virtual round of applause and the acknowledgement
thank you very much.
of
That's
your peers.
lovely.
So thank you for that.
Beautiful thing to have. Thank you very much. And it's been a great pleasure.
Thanks, Hugh. And so the only thing that remains is to thank you all for joining us this evening for the Crock Lecture. It's been a different format to usual. But we hope you've enjoyed it. If you've enjoyed it, pass on the link to anyone else you think might be interested. Thanks to all of our supporters for all your help during the year. It's been a difficult year, but we've kept the momentum going, and I hope we will have plenty of new exciting things to report over the coming year. So we'd love to see you back at some of our events over the coming year. But I think some of the good things from this period we will keep, and we will keep capturing the content and enabling you to catch up with our presentations later, should you so desire. So thanks again for coming this evening, and wishing you all very well for the rest of the evening. And as we approach the festive period, hope you get to have some rest and spend some time with families. Thanks very much.